So I'm going to go ahead and introduce our next speaker. Coming to the stage with me is Jason Tugman. Jason is the Director of Information Security and a Data Security Officer at Echo. And he'll be talking with us about healthcare policies and governance. Jason, thank you so much for joining us today. I'm excited to hear what you're going to be sharing with us and our community.
Well, thank you for having me. So everybody, I'm going to have a very interesting topic. I know everybody is at the edge of their seats for this, but I promise it's going to be awesome. So policies and governance of medical devices, when we think about that, we can't just think about the United States. We have to think globally. I know for myself, the Director of Information Security, as you mentioned, and I'm also the Data Security Officer at Echo. So Echo is a digital stethoscope company. We have an AI ML engine that helps nurses and doctors and practitioners detect heart murmurs. And so we use our AI engine. And so we're partnered with 3M. We use the Littman Core stethoscope, and we attach our device to that stethoscope. So being a partner of 3M means that we have to think globally. So as the data security officer, when 3M says, hey, we're going to go into this country, or we're going to go into that country, or when we expand into, say, Canada or Brazil or Japan, we have to think in that global sense. So our data security and our cybersecurity is not linked just to HIPAA and US laws, but again, that global view. So that is the view that I'm going to take today as I begin to share my screen. This one, in fact. And so I know that we're all very familiar with GDPR. And again, so GDPR, when we take that global view, we have to think first about GDPR. So I know that everybody in the audience is very familiar with GDPR. So I'm going to give you a pop quiz. I got 2 truths and a lie on this screen. And in chat, I want everybody to put what they think is the lie. All personal data, regardless of classification, collected from EU member states falls under GDPR. 1. 2, organizations must first comply with GDPR before they can use pseudonymized data, a word I can never say, pseudo data, before they can use that in their own means. So in other words, that's anonymized data. 3, organizations do not own collected personal data. Organizations are only the controller and or processor of EU personal data. Which one is the lie? Well, the truth of it is, they're all 3 truths. And we knew that. I know that everybody knew that. So when we look at least from my perspective at Echo is only the controller or processor of EU personal data. So as we think about the ownership of data and GDPR, we have to not only think about how we can use it, how we can use medical device data or the data that we collect, but also where we can use that data. And we'll get into that in just a moment. So again, I know everybody's probably very familiar with GDPR, but we've got 173 recitals and 99 articles. Those articles, or the core tenets of those articles, are there on the right-hand side. But the things that we really want to focus in on is that medical device data, medical records, and medical data is what's called a special category under GDPR. And so in that special categorization, there are increased requirements, most of which fall under the right to be forgotten, the right of access, privacy by design, a word we're going to hear probably pretty often in this talk, and the processing and privacy impact assessments. So if everybody's done data in Europe, we've probably all done a DPIA, which is the data processing impact analysis. So every time that you start a new function, for us, if we process data in a new way, we have to make a data privacy impact analysis. And all of that is to ensure the privacy by design. One thing that we have to remember when we look at GDPR is that member states, so EU member states, they all have the ability to add special requirements to GDPR. They can't remove things from GDPR, but they can add. And so one of the struggles that I have, and I work with my DPO, is whenever we go into a specific member state, say Germany or France, or we have to understand, or the UK, right? So the UK has their own data privacy, but it is mirrored almost exactly to GDPR. So in my mind, I treat them one and the same. But member organizations or member states can add requirements. They can say, we do not want special category data to leave our country. So now at Echo, if I look at that, that means that I have to spin up an AWS environment in that country specifically. So as we branch out globally, we have to think of our return. Is it worth for us to go into specific countries where we have to then stand up unique environments for our mobile apps, for our Android app, for our iOS app, for our Windows app, for our SDKs? We have to think about that in that global sense. But we also look at GDPR beyond just the EU. We think of it globally. So, for example, if we look at Vietnam, Vietnam has what's called we call it a store and forward. The data has to reside, the original data, which makes no sense. The original data has to reside in Vietnam, but we can process that data in the United States. So in other words, as long as we keep the original data in Vietnam, we can then process it in the United States. So our need to stand up a unique environment in Vietnam is just, we have to make an S3 bucket and stand up a small instance, and we can have all of our primary processing, the heavy lifting, in the United States. So understanding GDPR is the window into global requirements. India, just very recently, something that we were tracking very closely is India had a bill on the floor for the General Data Processing Bill. It's a 2019 bill, and it would have a lot of stringent requirements specific to that special category of data and many others. And so it was something that we at Echo were monitoring very closely. Now, just a couple of weeks ago, that bill was removed. We can talk about what that means for India, for citizens of India and their data privacy. But from our perspective, it loosens up, or at least it doesn't put those requirements on us. So we can look at that as a positive. The last thing that I'll mention for GDPR is Canada. Well, Canada is not in the EU, but remember what I said, GDPR is the basis for the world, except for the United States with HIPAA, but we'll talk about that with the FDA here in a second. So if we look at Canada, Canada is a great example of that special category of data. Now, during COVID, there was a relief where we could actually process Canadian medical data in the United States, and that was just to help for research and other purposes. But now that that agreement has passed, I think it expired rather early this year, or very late last year. We then have to look at Canada in the PIPEDA and what that means for global, or for their privacy. So if we can process Canadian data, Echo can process Canadian data in the United States, except for public institutions in British Columbia and Nova Scotia. And so if 3M or somebody sells our product into a public institution, so a public hospital, those data that are collected have to remain wholly and cannot be processed anywhere other than Nova Scotia or British Columbia. And so we have to make strategic decisions about how we are going to expand into Canada. So it's interesting. So that's why I bring up GDPR. Now, GDPR and HIPAA, what are the differences? So in HIPAA, we've got required and addressable statements in the HIPAA security rule, right? So required statements are shall statements. Addressable statements are should statements. So should and shall. Whenever you write a policy or a standard, I was fortunate to work with the Department of Energy on the cybersecurity capability maturity model. I've actually worked in Canada drafting cybersecurity standards for the oil and gas industry, as well as in the United States, drafting a standard for the cybersecurity of oil pipelines. And the goal of that was to incorporate by reference when and if Congress passes legislation for pipelines. So I've had a lot of experience in drafting standards. And when you look at that, the shall and should statements allow you, especially in the HIPAA, allow you to addressable, allow you to consider the risk of that statement or that control, and then do a risk analysis or risk justification for why you're not going to implement one of those addressable items. Now, GDPR is the exact opposite. GDPR only has shall statements. We begin with shall. But the leverage or the leniency that GDPR offers is that they take into account the size of your organization. So if you're a giant organization and you have the means and the ability, and it is technically feasible, the term that they use is used pretty broadly, if the control is technically feasible, then it must be implemented. And so we begin in GDPR with shall statements, where HIPAA has both shall and should statements, phrasing that we're going to hear. So we understand GDPR. Now let's look at EU MDR. So the new, it's been around for a while, but it just triggered was it this year or last year, where it's now a requirement. And so we're actually going through the EU MDR very, very soon for something here at Echo. So it's something that I have very close to my heart when we consider EU MDR. So if we look at MDR, we can't just look at it as the single document, the way that we would GDPR. We have to break it apart, and we have to consider how GDPR, how the Cybersecurity Act, how the MDGC, which is a 44-page document that really covers verification, validation, pen testing, security, risk assessments, threat modeling, a word we're going to talk about quite a bit here, vulnerability remediation, incident response. And then the IMDRF, the actual, we call the MDR, that covers the pre and the post market. And so that collectively is MDR. So we can't just look at the documentation about what is required in the pre-market, what is required in the post-market. In the FDA land, that would be guidance specific to pre-market and post-market. We'll talk about that in a second. But look at a couple of things that I want you to look at: threat modeling and SBOM. Just have that in your mind. So again, IMDRF medical devices is really about pre and post market, risk assessment, security testing, SBOM, architecture design, another word that we'll talk about, pre-market information sharing, vulnerability disclosure, and incident response. All sounds very familiar. MDGC is really classic risk management. It's got some special pieces in there about threat modeling and others, but it is very much classic risk management that must be incorporated, and then through the context of medical device and medical data, have the pre and post-market considerations. So I'm blazing through because I've got a couple that I want to talk about here. Talking about global cybersecurity is more than a 20-minute talk, but I'm hoping I'm spurring up thoughts in your mind. AI ML. Now that's close to my heart because Echo has an AI engine back in our AWS environment that helps clinicians detect heart murmurs and other things, and heart and lung sound auscultations. And so AI, I pay a lot of attention to AI guidance and AI regulation across the world. So no surprise, the IMDRF, which is the International Medical Device Regulation Forums, something probably everybody's familiar with, but it's important to know that it is a consortium. It is a grouping of organizations. And you can see by this list, one, it's global, and two, the United States is on there, right? So that authority is really that guiding authority, similar to GDPR. It's that guiding authority. So when we look at AI and ML, we can kind of look through this. I'm going to breeze through pretty quickly, but we have to think about artificial intelligence and machine learning. So it's the entire thing. So they're drafting the artificial intelligence, the artificial intelligence medical device working group. So they're actually making guidance documents for AI and ML for medical devices. So they're really going to talk about trust. There's a lot to go in here, which I won't cover in this, but you have to think about risk and the risk categories. The document actually lays it out pretty clearly. Again, for time, I can't go into it, but no surprise, the FDA has a draft or coming a draft for AI and ML FDA guidance. No surprise that it will follow the IMDRF AIML trust categories. Back to this, trust categories. The draft will likely be in next year. And the FDA, if you have AI, and this is what we did with the FDA, is they highly recommend going through the pre-cert program. So in other words, talk to the FDA early and often if you're in pre-market. So this is coming, and it's no surprise that it will follow the IMDRF, which that draft is publicly available. We all are very familiar with the pre-market guidance, the new draft, but we have to look at SBOM and threat modeling. That is the word that's coming up again and again and again, threat modeling and SBOM. Again, we're going through a pre-market right now, and it is something that I've spent most of my week, the past couple of weeks, doing our SBOM and threat modeling and shoring that up for our submissions. So when we talk about should and shall statements, the FDA has should statements. You should incorporate. There's no teeth. The Patch Act, which is a bipartisan bill, will look at that, SBOM, vulnerability disclosure, and other pieces. Threat modeling is kind of in there tacitly. And they're making those from should at the FDA to shall in the Patch Act. This is anticipated to pass. It is something we should all pay attention to because, again, we're going much more in that GDPR land of we're going away from the should and into the shall, something we should all pay a lot of attention to. So this is my last. There are specific guidance documents that were just released this year, early this year, thankfully. The playbook for threat modeling medical devices that was critical for my understanding and a awesome document. Also was drafted by MITRE. I'm a MITRE. I used to work at MITRE. I was a department chief engineer at MITRE, so I have a soft spot in my heart for MITRE. And then the SBOM, which is NTIA, they drafted guidance on the SBOM. So if you're unfamiliar with or you need to get up to speed, please look at those two documents. They really are incredibly accessible and very, very informative. So if you're just starting your journey in SBOM and threat modeling, I highly, highly encourage you to check those two documents out. So I just did global cybersecurity for medical devices very quickly. It's a massive topic, but if anybody has any questions, let me know, and hopefully we can be able to answer them either here or offline or anything else.
Thank you very much, Jason.
Yeah.
Let's see. Does anyone have any questions? Let's give it a minute. And I know I saw a comment coming through about having the slides because you're going really quickly.
Yeah, and you know, again, it's global cybersecurity. So in 20 minutes, I got to move fast. In fact, I don't even know if I made time or not.
Oh, it's good. Really.
Yeah.
I appreciate that. So we'll give it another quick minute here. Let's see, we have questions coming through from Stacy here.
When it comes to devices, what seems to be the most common type of problem you run into in terms of protection? Is it network segmentation or malware? No, it's not. You know what it is? It's USB ports. If you go through any regulation, FDA, EU MDR, Japan, I forget the name of that one. If you have a USB port on your device, that is the thing that they look at the closest. So if you have a USB port, make sure you, if you're going to use it for update firmware or something like that, and only used by skilled technicians, put that USB port inside the device. So I used to work for a CRO. My whole job was to draft the pre-market documentation for 510Ks. And I tell you, that USB port was the hardest thing to get through the FDA and the CE marks. So pay a lot of attention. If it's external and it's only for charging, make sure it's read-only, and use your penetration test and talk about that USB port. And I'm telling you, that's the number one thing. After that is Bluetooth. The FDA really doesn't like Bluetooth. Swintooth, the other couple of years ago, the FDA pays a lot of attention to Bluetooth as well. So BLE. So.
Awesome. Any other questions?
How is it organizations don't lock it? Right. Well, we have to understand that specific to the FDA, cybersecurity is brand new. So they're still figuring out. So Dr. Kevin Fu and Suzanne Schwartz, they are really building that from the ground up, and they have to train their reviewers. And so they look at a couple of things, and you look at that threat vector, that USB port, if it's exposed, that's a primary threat vector, especially depending on the type of your device or the classification of your device, type, class 1, 2, or 3. Highly important.
Love it. Thanks, Jason.
Anytime. Thank you for having me.